This is Dr. Michelle O'Donoghue reporting from Medscape. Joining me today is Dr. Sunil Rao, who is the Director of Interventional Cardiology at the NYU Langone Health System. And importantly, he was also the chair of the recently released 2025 ACS Guidelines. And I served as vice chair, which was a pleasure to work with you on this. So let's just really break down the guidelines for people who maybe haven't had the time to do a deep dive, but are interested in the key takeaways and next steps.
It was great to work with you as well, Michelle. I mean, it was a great team that we had. A lot of societies worked together on this set of guidelines. I think there are a couple of things that we should probably mention about the document itself. First is that we really focused on type 1 myocardial infarction. As people know, the universal definition incorporates other types of myocardial infarction, as well as other causes of myocardial infarction, such as spontaneous coronary artery dissection or MINOCA. We elected not to comment on those. They're largely covered in another document called the chest pain guidelines. So we were very focused on type 1 MI. The other thing is that we combined, I think for the first time, both ST segment elevation MI and non-ST segment elevation MI, which, you know, at first pass seems like, well, that's very logical, and there are overlaps in terms of pharmacotherapy and perhaps some invasive strategies. But it did also create some challenges with the layout of the document itself.
Exactly, because the weight of the evidence for some types of therapies may be stronger for the STEMI space or the non-ST elevation ACS space. And so there were challenges there for sure. And I think also the fact that the guidelines hadn't been updated in more than 10 years, you know, there was a lot to cover.
I mean, we're lucky in cardiology because we have so many randomized trials, but it creates a huge challenge to make a document that's, you know, both comprehensive and at the same time digestible by the clinician so they can apply it at the bedside. And I have to hand it to our writing committee and to the staff at both the ACC and the AHA. I think that the document really is very applicable.
Let's start with intracoronary imaging. As an interventional cardiologist, I know that some of these recommendations have been quite well received. What is the recommendation there?
Yeah, so we gave a Class 1 recommendation for the use of either intravascular ultrasound or OCT to guide coronary intervention in what we called complex cases. And that's really driven by the fact that since the revascularization guidelines were released, and it did not get a Class 1 recommendation in the revascularization guidelines, there have been several randomized trials that have specifically included complex coronary intervention. And that's why that wording is used in the guidelines. I mean, for the viewers, we should mention that there are sort of a set of ground rules around how we incorporate evidence. I mean, we try not to extrapolate, you know, beyond what the randomized trials have shown. There has been some criticism of that, saying, shouldn't we be using intracoronary imaging in all cases? And I think there's a strong argument to be made for that. But really, the clinical benefit was shown where complex cases were included, and that's why we use that wording.
Great. And now what about the new recommendation for mechanical circulatory support in patients with cardiogenic shock?
Yeah, so that was a great discussion that we had. You know, in the past, mechanical circulatory support was not given a strong recommendation. And I use that term sort of as an umbrella term to incorporate all mechanical circulatory support devices. Since the last set of guidelines, there have been some trials that have been done in the cardiogenic shock space, like IABP Shock 2, showing no benefit of routine use of intra-aortic balloon pump. Again, I'm using that term routine because that's what the trial studied. However, last year, there was the release of the Danger Shock trial, which was a randomized trial of patients with cardiogenic shock randomized to the use of the microaxial flow pump, also known as Impella, versus sort of usual care, with the primary endpoint of 180-day mortality. Mortality was significantly reduced in the patients who received the microaxial flow pump. We gave it a Class 2A recommendation. And people may be wondering, if it did reduce mortality, why 2A? Well, there was a downside of using that device. It's a large bore vascular device, so patients did suffer from vascular complications, bleeding complications, and so it's really about the balance of risk and benefit. There does seem to be a benefit, but there is a risk associated with it, so we felt like we got it right with the Class 2A recommendation.
Great. Now let's think about lipid-lowering therapy, because previously the European guidelines had been perhaps a little bit more aggressive about lower LDL cholesterol targets. Where are we now with the latest ACS guidelines in that regard?
You certainly have been leading the field in that. I think we all are recognizing that probably lower is better, and we certainly are giving a strong recommendation to patients who continue to have LDL cholesterols that are around 70 despite best therapy or maximal dose statin to add other agents to try and get that lipid level down. What are your thoughts about how we phrased some of these lipid-lowering guidelines in the ACS guidelines? You think we got it right?
The weight of the evidence really does suggest that lower is better. We've done many analyses looking at whether or not there does appear to be any kind of clear basement in terms of going lower doesn't make any further difference. But in fact, I think most of the trials really do support that the lower you achieve the LDL cholesterol, the lower somebody's risk of having a major adverse cardiovascular event, and in the absence of any clear safety signal. We now have a 2A recommendation for intensifying lipid-lowering therapy further if your LDL cholesterol is above 55 milligram per deciliter, so that zone between 55 and 70. High-intensity statins for all, or maximally tolerated statins for somebody who otherwise may not be able to tolerate high intensity, but then early initiation of additional therapy as needed, and not requiring that necessarily ezetimibe be added first. I think it really depends on how much LDL lowering you need to achieve. And so there are other types of non-statin lipid-lowering therapies, PCSK9 inhibitors, for instance, bempedoic acid, inclisiran. Those are all available in our arsenal now. And for all of them, we believe that their benefit is really proportional to the magnitude of LDL reduction.
We should underscore this is for the ACS patient who's really already defined themselves as being high risk for events. So really getting aggressive about secondary prevention is really, really important. So maybe I'll ask you, what are your thoughts on the antiplatelet therapy or recommendations that we included in the document?
I think that it's appropriate that we have for initiation of therapy that ticagrelor or prasugrel are going to be appropriate for many patients. There was discussion about prasugrel versus ticagrelor. There's some evidence out there to support that perhaps prasugrel may translate into better outcomes, but we were waiting for further evidence. So both ticagrelor and prasugrel are preferred options, and then clopidogrel for those patients who otherwise may not be able to tolerate it, or other types of barriers to the more potent P2Y12 inhibitor. Then the challenge becomes duration of DAP. We still have the default 12-month recommendation, but we now also offer a Class I recommendation for ticagrelor monotherapy, so you could discontinue the aspirin after 1 to 3 months to reduce somebody's risk of bleeding, because I think that the trials right now have all been generally supportive of the same concept, that by discontinuing aspirin, you can quite markedly reduce somebody's risk of bleeding. And when you continue ticagrelor monotherapy, that there doesn't appear to be a clear excess in the risk of MACE. So not a clear price to pay. Clopidogrel, the jury's still out, and that's why we had a weaker recommendation on that front for doing clopidogrel monotherapy, because at least one trial suggesting that there could be harm.
There's been some discussion since the guidelines came out about, why not give a Class I to just 6 months of therapy? And I think, again, we're talking about the ACS patient, and there have been some trials that suggest that kind of shorter DAPT may increase MACE. And so I think that's why we went with the foundational strategy really is still 12 months of DAPT. We have a lot of areas that we still need a lot more data on. That's one of the future directions that we talked about in the document. How to treat MI-associated pericarditis, for example. When does that patient with acute coronary syndrome become a chronic coronary syndrome patient? This document is current right now, but given the way our field is going, it's probably going to be due for an update in the next couple of years.
Absolutely. Well, thank you again for breaking this down with me. It's very helpful, and hopefully people find this useful as well in terms of just being able to distill the information. Signing off from Medscape, this is Dr. Michelle O'Donoghue.